Good afternoon, friends. We're already behind schedule, so let's not take too much of time in introduction. We'll start with the lectures, and in between the lectures, we'll be taking questions. So our first speaker is Dr. A.K. Jain. He's going to talk on Vivinex aspheric design. What is the role of the design in the performance of the IOL?
I think in the meantime, when Arun is fixing his presentation, you all know there has been a lot of innovation in the cataract surgery. And one of the most important features has been the advancement in the field of technology in IOL designs and its concepts, which has given us the vision to not only to patient, to surgeons also, to think how to make best use of these newer technologies for our patients. And Hoya has done so much of work in this area. I remember my younger days when we started using IOLs. Those days also we used to have a 3-piece Hoya lenses as one of the major lenses at that time also. I think. And they are the people with the optics, and the best optics can come from the Hoya itself. And we have now so many other designs giving us a good results. Yeah, Arun, he's ready now.
Yeah.
You know, Arun is professor. He just completed his tenure in PGI Chandigarh. Now he's working in a different institution. Has done a great work in this field, and his experience will really count. Dr. Arun, please.
Okay, thank you, Dr. Titya. And at the very outset, I'll thank the organizers for giving me this opportunity. Today, I'm going to talk about this Vivinex platform, how this Vivinex aspheric design help in improving the post-operative image quality in our patients. I have no financial interest in the subject matter of this talk. So first of all, let us know what is this Vivinex platform. It has a proprietary aspheric optic design to which I will come later on. And in addition to that, it has a new glistening-free material, new delivery system which is excellent, and also it has a PCO prevention mechanism. There are so many attributes to this. And before I go into this proprietary aspheric optic design, as all of us know that these higher order aberrations accounts for 10 to 20% of optical defects. As of now, we are, in most of the IOL, we are addressing only the spherical aberration. We don't never talk about how we can counteract this coma aberration in this patient. These are the two most common aberration which accounts for 10 to 20% of optical defects. And the impact of these two aberration is quite a lot on the quality of vision, which is almost equivalent to last two lines. In terms of higher order aberration, it is around 0.25 micron of higher order aberration is equivalent to around 0.2 diopters in terms of spherical error, which is equivalent to last two lines in the Snellen chart. So this has quite a bit of effect on the quality of vision as far as quality of vision is concerned. In a perfect eye, you get a point spread function, but if you have coma or spherical aberration, you get a spread out of the point spread function. And in our eye, because the position of the eye and the tilt in the optical axis, we have naturally occurring coma aberration, which could be vertical or horizontal. And as far as also this corneal coma is compensated by also the decentration and tilt of our human crystalline lens. But as we age, the internal optics of the lens also changes, and cataract surgery gives us opportunity to manage these spherical aberrations. Corneal aberration, as we all know, is to the tune of 0.2 to 0.3 plus micron. And aspherical IOLs are designed to improve the image quality. And However, again, I said that effect of coma on image quality is not routinely addressed or considered. And this is the two eye of the same patient. In one eye is aspheric IOL, in other eye is the spherical IOL. You can see the point spread function with aspheric IOL, and the sterile ratio is very close to 1. So addressing the spherical aberration improves the quality of vision. But again, coming to after doing the cataract surgery, the causes of coma aberration still remain in the eye. And even if you implant aspherical IOLs which are not addressing this coma aberration, you will have deterioration of quality of vision in case the decentration of IOLs happen. So we should be considering this aberration also while doing a cataract surgery. As you can see, as there is a decentration of, and this is more so in aspheric IOL. Once aspheric IOLs decenter, the effect on quality of vision is much more. As you can see in aspheric IOL compared to spherical IOL, deterioration of quality of vision as there is a decentration of the IOL. Same is true about the tilt of the IOL also. So what is this Hoya platform special aspheric optic design? It neutralizes the corneal positive spherical aberration to some extent. It also tolerates the anatomical misalignment as we have in our normal human eye, and it also compensates for coma aberration. So what is this patented optic design? So in the central 1.2 and area 1.2 surrounding this area, we have a slight area of positive asphericity, then a slight area of 1.2 millimeter diameter of negative asphericity, and then there is a continuous zone of negative asphericity. What this does is, the first element, it produces a typical plus coma of when there is a decentration of the lens, and the second element, it produces equal and opposite coma when the lens is off the axis. So once there is a decentration of the lens, it compensates for the coma like a normal human crystalline lens. So is there any evidence to this with this lens? This was the study conducted by Pablo. This was an experiment study in vivo, and they have shown, they compared 3 IOLs, the Vivinex, the Technis, and the third one, the IQ Alcon. And they found that this Hoya Vivinex platform was most immune to optical degradation caused by the decentration of the lens. So, but this was a bench-side study. So, and this was shown that reduced coma was caused by off-axis alignment of this lens. This was again in lab, and it was shown that in the presence of decentration of Vivinex, as the decentration increased, the visual sterile ratio was much better maintained with Hoya Vivinex lens as compared to the other 2 lenses. So this was, so do we have a clinical evidence of this? Because in lab, everything is aligned on the optical axis, but human eye is not a perfect eye. It only works at 40% efficiency. So there is a misalignment of geometric optical axis and a misalignment of visual axis. So to prove this, we did 2 studies. In first study, we was published in 2022, where we compared Vivinex with the Alcon IQ lens, and the second study published this year only, 2 months back, where we compared this lens with the Technis lens. So let us see what were the results. So this was done 4 years back, and in this we randomly allocated 1 eye of each patient to either of the lens, IQ or the Hoya Vivinex, and patient underwent surgery, and after 3 weeks of surgery, we did all these tests, contrast sensitivity, and we did a eye trace evaluation to calculate the decentration of the IOL as well as higher order aberration, and as well as we noted the sterile ratio in these patients. So this is one case with the dilatation of pupil. You can see the yellow one is the point of the center of the lens, blue is the geometric center, red is the optical axis. So on the eye trace, you can measure the decentration of the lens from the optical axis as well as from the geometric axis. This is a centered lens, but this is a decentered lens. As you can see in this case, the decentration is around 0.66 millimeters. So this was done in all the cases, and higher order aberrations were noted in all the cases. And what we found was, with increasing angle alpha, there was a deterioration of Strayer ratio in the IQ lens, but not in the Hoya Vivinex lens. And evaluation of total higher order aberrations, trefoil, and spherical aberrations showed that in Hoya Vivinex lens, with increase in angle alpha, there is a negative correlation with the higher order aberration. This doesn't hold true for IQ lens. This is apparent in this graphical form. This is with the increase in angle alpha along the x-axis, and we compared the Strayer ratio, higher order aberration, and spherical aberration. As you can see, as the angle alpha increases, we have a maintenance of Strayer ratio, whereas in IQ lens it goes down. Similarly, the relation is negative with the spherical aberration as well as higher order aberration. So we concluded from this study that in vivo, the geometric axis and visual axis do not coincide. Hence, the result may vary from simulated trials like we have done in vivo study. So decentration of the lens is best measured with the respect to the visual axis. All of us knows that all the ablation procedure or optical devices should be centered onto the vertex of the cornea. And in eyes with large angle alpha, the aspheric balance curve design performs better by inducing lesser higher order aberration and maintaining a better Strayer ratio. So the outcome of this current study have demonstrated that statistically better parameters, no deterioration of Strayer ratio with increasing alpha in Vivinex group, which appears to suggest that in such situation where the angle alpha is more, or there is chances of decentration of the lens, like in subluxury lens or weak zonules, one can choose this lens to have a better tolerance to the decentration of the lens in terms of quality of vision. So this second study was comparing the this lens Vivinex platform with the Technis lens. So again here we studied the decentration of this lens in one eye. This is a contralateral eye study. One eye we put one lens, in another eye the other type of lens. It was randomized, and the results were again the visual internal Strayer ratio was higher, statistically higher at all pupil sizes, and the spherical aberration value were lower at all pupil sizes in the Vivinex group. Though the decentration of the Vivinex IOL was more as compared to the Technis lens, still the quality of vision was better in Vivinex platform. With an increase in angle alpha, there was a greater decline in visual Strayer ratio for Technis. However, there was a statistically significant decline at 3 millimeter, non-statistical significant decline at 3 millimeter pupil size for Technis lens. So this shows that the spherical aberration were statistically less in Vivinex group as compared to the Technis group at 5 millimeter pupil size, and this shows at all the pupillary diameter there was a statistically significant difference in the Strayer ratio, and the Vivinex group always had a better Strayer ratio at all the pupillary distance, though it was not statistically significant at 3 millimeter. At all other pupillary diameter it was statistically significant. So again it shows the same trend. The visual Strayer is better with Vivinex. It's maintained better as the angle alpha increases, but there is steep decline in the other IOL. Again, the Technis has a much higher asphericity. Higher is the asphericity, it is more known that more is the deterioration of vision with the decentration of the lenses. So similarly, a higher order aberration and spherical aberration show a better result in a Vivinex platform. So the conclusion of this study was, in comparison to an anterior aspheric design IOL, which is Technis, the ABC design or the patented optic design of the Vivinex platform, it yielded better quality of vision, neutralized spherical aberration to a large extent, and provided a relatively superior quality of vision with decentration. So to summarize, now all the Hoya these IOL, be it Vivinex, be it Geometric, be it Hoya Impress, all are having the same platform with the same optic design. So to summarize, this unique negative aspheric lens platform of Vivinex is less sensitive to alignment than traditional negative aspheric optics lens. This combines the benefit of traditional negative aspheric optics with that of a neutral aspheric. Like in neutral aspheric, decentration doesn't lead to deterioration of quality of vision. And the visual axis compensation that happen in natural eye benefits, since visual axis doesn't typically coincide with the IOL optic center. So this patented proprietary aspheric optic design reduces the coma that is typically induced by decentration or tilt of the traditional negative aspheric optics, and improves the quality of vision in terms of maintaining internal stereo ratio. Thank you so much.
Thank you, sir, for that wonderful highlight of that ABC design. I'll request Dr. Ramamurthy to please be on the chair. Welcome, Dr. Namrata Sharma, ma'am, Chairman Scientific Committee. So just two quick questions. I mean, I just noted that you highlighted that negative correlation with the Strel ratio. So, I mean, how do you account that? The more decentration, and why the Strel ratio was increasing despite the lens getting more decentered?
So, as we discussed in the optics of this design, as it decenter, it negates the coma aberration. So by negating the coma aberration, it improves in terms of, that's what
I mean, that was
we
a
are
quite
contemplating.
Interesting observation.
There could be so many other factors, but one of the main factors, because coma and the spherical aberration these are only two aberrations which affects the central part of the vision. Rest of all aberrations are affecting the peripheral part of the vision, which comes into play in mesopic and scotopic condition. Spherical and coma aberration comes into play even in photopic vision.
Just a second quick question. Do you then recommend that this becomes a universal IOL to be implanted in people who do not have an access to an eye tracy? This becomes a very forgiving lens when you have a large angle alpha. So I think with this ABC proprietary design, and this Vivinex then should become one of the the mainstay of monofocal IOL implantation technology.
Yeah, I think so, but if you really want to customize IOL implantation, then ideally one should be measuring the spherical aberration also in each patient, because in normal population there is a variation of spherical aberration, corneal positive spherical aberration from 0.1 micron to 0.4 micron. So you have to choose a IOL also, so that you also leave behind some residual positive or negative spherical aberration to the tune of 0.1. There are enough number of studies, because otherwise you will have a very flat pinpoint sort of point of focus, and the depth of vision goes away.
Thank you, sir. So yeah. I think we have next Dr. Anaga, and she'll be talking on when my patient demands spectacle-independent lifestyle.
Very good morning to all of you. Thank you so much, Dr. Sonu. So basically, we'll be speaking on how the trifocal family of geometric helps us to achieve spectacle independence. So basically, in today's fast-moving world, where patients' expectations are reaching sky high, we don't need just the distance clarity, but also important is the intermediate vision as well as very, very good near vision. And all of us to a certain extent, fear multifocal IOLs for the fear of having dissatisfied patients who will keep complaining and keep coming back to us with waxy vision or glare and halos. Yes, of course, the increased cost and the fear of having to do an IOL exchange. And as times keep changing and so are patients' profiles who are being now more educated and demanding, it becomes more of a challenge to select not only the right patient, the right lens, do a good counseling, and definitely do a precise biometry and surgery so as to give the patient a perfect visual outcome. So in our center, we make it a point to have a repeat reading for all our premium patients, be it torics or multifocals. Definitely ensure that the patient is not dilated or you don't do an applanation before that so as to have a pristine cornea. We also include an OCT macula to rule out any very mild changes in the macula similar to an ERM or a lamellar macular hole which could impact a clinical visual outcome. A good ocular surface assessment, ensure that the ocular surface is good. If not, then you may need to treat it pre-op. Topography in cases of astigmatism so as to rule out irregular astigmatism which can cause higher aberrations and can impact the quality of vision when you're using a toric multifocal, a pupillometry and an angle alpha so as to have a minimum of glare and halos. In case of astigmatism, we just put in the K1, K2 onto the Barrett toric calculator and see whether the patient needs a toric and the patient is advised accordingly. We don't have a specific threshold of a 1 diopter or a 0.75 diopter, and probably that is why the low power torics are also, the numbers are increasing. But we are giving good vision to the patients. So we also discuss the options of toric multifocals and the other options that we have to the patients depending on their affordability. We all know that yes, an ideal multifocal IOL is very elusive, similar to an ideal wife or an ideal husband. And selecting the best multifocal IOL for your patient sometimes can be challenging. So when you're doing a talk with your patient, you need to give them good chair time pre-op so as to have less chair time post-op. Speak to the patient regarding their lifestyle choices, their work activities, what distance they usually read, and what are their visual expectations, whether they have understood what they are in for. Explain to them the principles of the various options that they have, and remember that a trifocal is basically a combination of two kynoform profiles, and you have these steps which give you good vision at different distances but would also have loss of light as we discussed in the previous session. So when your patient wants spectacle independence, and what we do at our center is ask them 3 questions. The first is how much of night driving do they do, whether it's regularly, whether it's sometimes or never. A patient who regularly does maybe daily, say Bombay-Pune night driving, you would avoid using a trifocal. You'd think of using an ADOF or best probably an advanced monofocal. Sometimes you counsel them about the glare and halos and whether it would be acceptable to them. If they never do, then definitely you can give them the choice of trifocal IOL. If the night driving is more important to them than the spectacle independence, again, it's better to avoid a trifocal. If the patient has understood and accepted that he might have a glare and halos and he would still want to opt for spectacle independence, the second most important question is how much of intermediate vision he requires, whether it's computer work or any other kind of intermediate vision. So then it becomes important for us to address that intermediate vision, whether it's trifocal or an ADOF with a micromonovision. And if the patient sometimes only requires an intermediate vision, still trifocal and ADOF would be the best choice. There are still patients who would use reading distance and things at near, which is of more importance to them. For them, having crisp near vision or crisp vision at near becomes more important to them. So you need to also, in such patients, decide the near addition. So when you are having near vision, you have patients reading, say, for at this distance versus at this distance. You need to see what add your multifocal or trifocal is giving you. So what we do is we just give them a reading card regard in the preoperative workup and see at what distance they are more comfortable, and accordingly you advise what lens they would basically suit them. In any case, do not promise 100% spectacle independence, and always say that a small number of patients might require fine focusing for distance as well as definitely for near. So if your patient selection and expectation setting is meticulous, trifocals are definitely performing better in all these distances. And this was an interesting article which compared 5 presbyopia correcting IOLs. This has an optical bench assessment. So this was what it showed, is basically all these lenses which are now available have a near light distribution of say around 25%, 21%, or around 28 to 36% depending on the pupillary size. So what's new today? So what we need today, as we said earlier, was if a patient expects a better near vision or crisp near vision, we need to emphasize on that. Plus, if you have an added advantage of a preloaded technology, minimum or no rotation because of a better optics and a better stability with minimum of PCO, today we have with us the Vivanex geometric trifocal family, which gives us spherical aberration correction, which is more tolerant to coma, especially important in patients where there could be a slight decentration, a good material which is glistening free and no calcification, a design which we have used for the last so many years with the Vivanex technology, and definitely a preloaded advantage where it consistently delivers a very smooth intraocular implantation, be it a 10 diopter or a 30 diopter lens with equal elan. So this has an intermediate ad of 1.75 and a near ad of 3.5 diopters. There are two in this family, the Vivanex Geometric and the Vivanex Geometric Plus. The central truncated diffractive optics of 3.2 millimeter zone. So if you look at the difference between the two, I would not go into the video's details, which was described already yesterday. So this was the first day post-op. You have a beautiful central zone which is perfectly centered on the pupil. Important to note is the Vivanex Geometric gives you a very good vision for distance, and the Vivanex Geometric Plus gives you very good vision for near. And both of them have the central hump in the intermediate zone. So if you have a patient where there is a full range of good vision in good light, so if you see the pupillary size in the 3 millimeter zone, you have a very good Vivanex Geometric Plus giving good near vision, whereas in the slightly dilated pupils, you will have a very good vision for near also. So this is again, you can see the arrow pointing to the very good vision for the Geometric Plus, even in poor light. Important to note is the loss of light is just around 9.9%. And for near, with the Geometric Plus, the near distribution, as we saw in the earlier slides, the maximum was around 21 to 25. Here it's 38.6%. So that gives us the extra edge for a clarity of vision for near. So the patient's complaints about having to depend on glasses for near is usually very, very less. So this is an important defocus curve. So if you look at the bold black line, which compares, which basically uses a geometric in one eye with the paired approach in the Geometric Plus in the other eye, it gives you excellent vision for distance and an excellent vision for near, compared to an approach where you have Geometric in both eyes or Geometric Plus in both eyes. So this is our experience. Till date we have finished, actually till date 125, we're just completing, 125 implants, and sharing today 70 eyes implant data of more than 3 months post-op. So there were most of them having better or more than 6/9, 6/6 for distance, intermediate as well as for near. And if you see the defocus curves for all the 3 categories of Geometric Plus or Geometric in both eyes, as well as the Geometric Toric and Geometric Plus Toric in both eyes, the defocus curves are similar. So you can use either in both eyes. So you can use Geometric in the first eye and Geometric Plus in the second eye, or other way around. The spectacle use usage was minimal post-op. The photic phenomenon were minimal, and patient satisfaction was very good. The reading speed was very good, especially with the Geometric Plus, even in poor light. So it basically showed that the vision for distance, intermediate, and near was very high. That in toric platforms, the stability was very good. And finally, to conclude, it gave us very good visual outcomes, satisfied patients, spectacle freedom, minimum of dysphotopsia, ease of implantation with the preloaded technology, boosted our confidence, and our counseling, which was important, where the patient's consent also was specially taken for having realistic expectations. All in all, will give us very good visual outcomes and happier patients. Thank you so much for your kind attention.
Just one question. Do you really think the pairing is needed with Geometric and Geometric Plus in your practice? What have you seen?
So we have used earlier Geometric also in both the eyes. When you have done Geometric in one eye, the patient is happy with the near vision. But when we know scientifically that the Geometric Plus will give us even better for the near, there is no harm in using the Geometric Plus in the other eye and giving the patient that extra advantage. There are patients who will, for example, those patients who are not doing much of going out and who are using only things at near, we would in fact put in Geometric Plus in both the eyes in rare situations.
I think the speciality about this lens is that this is the only lens which plays around with the light distribution, keeping the power same in for both the types of lenses. As Sajay asked, I also put a Geometric as my go-to lens in the first eye. The patient is perfectly happy, quite comfortable. His or her visual demands are such that they are quite. I go ahead and put the Geometric in the second eye also. It's just like putting a low ad multifocal and then you put a higher ad in the second eye. But in case the patient says my near vision is less than optimal, then we go ahead and put a Geometric.
So in that case, does the patient read N8 or his clarity at N6 is less?
To me, more than N8, N6 is the visual satisfaction of the patient, which is important.
So, but that could also be because there is still a cataract in the other eye yet to be operated, and patient might need some time to adjust.
No, intuitively the combination would work well, but if you put the first this eye, and if it is patient is absolutely happy, then sometimes repeating the same lens also works quite well, at least in my hands. And I would say that, nowadays, rather than discussing about multifocal lens as to me, multifocal lens is the go-to lens if the patient can afford it. And then you exclude patients who cannot have it. And I think most of our practices are wearing
Yes,
around
definitely, sir.
So I think thanks, Anaga, for that wonderful talk. And now we have Professor Dr. Mahipal Sachdev, and he'll be talking on intermediate vision benefit with higher spectacle independence.
Thank you very much, Sonu, and thanks for having me in this particular session. Can I have my slides, please? Yeah. So I'll be talking about intermediate vision, which we have to just discuss as to what it is. And as we are looking at in this particular session of discussion, what are the options that we have got apart from what has been talked about just before me, that is the geometric, which is the trifocal lens, or you have the EDOF, or what you have the monofocal lenses. Is there anything else that is available? And this has been the terminology that has come today is called as the enhanced monofocal or the monofocal plus. What are the outcomes of this particular lens, and what are the needs, and what are the clinical experiences that we have had at Center for Sight? So the monofocal options that are available today is that you came up with the foldable lenses. Obviously, the non-foldable went on to the foldable, and then within the foldable lenses, the optical properties, apart from the physical properties of being a three-piece lens, went on to a single-piece lens, and then you looked at the optical properties, and which are, you had all the lenses that were coming to you were the aspheric monofocal lens. From the aspheric monofocal lens, we went on to a new concept which is called as the aspheric lens or the negative aspheric lens. So that is what it is. So the companies have tried to get onto as to what is the asphericity that you need to correct. And I think the jury is still out whether you want a zero asphericity or you want something which needs to be at what particular level of correction that is there. So current day monofocal, let's look at what are their limitations. The present limitations that are there in the current monofocal is that they give you good crisp vision for distance vision, but the intermediate vision is flawed, as also the near vision is flawed. Now, as you know that the present lifestyle, if you go on to anybody, the iPhone always throws up the number of hours that you spend per day on the iPhone and whether you are up from the last week or what. So depends whether you are 6 hours or 4 hours or 8 hours, but you are there, and then you have the computer which is there. So the lifestyle has changed significantly, and we are today, I would say, also from becoming just couch potatoes looking at televisions, we are now looking at the phones, whether we are in the railway or whether we are in on the dais or wherever we are. So that's what we are looking. So let us understand as to the need. So the need, therefore, is that the foldable lens, you went on to the spherical, the aspheric, and then you have the enhanced monofocal. And what the enhanced monofocal is doing is trying to get you this kind of vision, because this is what you are using majority of the time. So you are either looking at the distance or you are looking at something which is nearby, which is the computer, etc. So that is where you need. So intermediate vision today is very, very important for an individual, even if you are driving, though you are getting now Teslas and all, which are going to be AI driven, but still you need to look at the speed board, etc., and see as to what it is, or maybe the Google map is going to tell you where to go or where not to go. So the new lens on the table, which is there, we were all aware of the Vivinex lens, which has the aspheric surface for spherical correction, etc., which were tolerant to coma. It was tailored to, this new lens was tailored to give you some amount of intermediate vision which is there. Now it has the same hydrophobic acrylic material which one is used to. It is glycerin free, there is no opacification, C-loop 13 millimeter, full 6 millimeters optic, low PCO that you get with outstanding rotational stability. So the problem just now today is that the Impress, which is the lens that has been launched, does not come in the toric variety. I don't know when the toric variety is going to be available, but toric ka vara hai iska, pata nahi. Okay. So anyway, I think that is the only pitfall that you have, that obviously it's a registration process. I think that's about it. And this is what we are. You can easily push it through a very small incision which is there. So this is how the lens looks. Obviously proprietary, but what they say is that they have done something on the central 2 millimeters, which is a smooth combination, and maybe they have induced some amount of abrasion which is there on the aspheric surface. But the rest of the lens, apart from this 2 millimeters, you can see this is the central zone which they have played with. The rest of the surface is just about the same which you have in their Vivinex lens, which is the monofocal lens. So what they have done is that there is a range of focus. So it's quite similar to maybe saying that a EDOF lens, but there are no rings in the lens. That is the main thing, and it is only confined to the central 2 millimeters, which is giving you a certain depth of focus. So this is what the lens has. So this is a standard negative asphericity. This is the 2 millimeter, and this is the anterior IOL surface which has the bump. So this is what they have done on the lens, and what it actually does is that it adds about 1.1 line. So this is the standard monofocal. You see that there is a strong decay that you have for the intermediate and the near vision. But when you go on with the monofocal plus, this is how the decay curve looks, and you can actually look at 1.5 diopters of defocus that the patient is able to withstand. This is the multi-cert injector which you have, which you are all aware of. Just to show you a small video, the ease of insertion, you can see this is the viscoelastic that is being put into the lens. The cartridge that goes in, this is a patient with the iris retractors, that's the lens which is going in, you can see, and round capsular axis goes in and sits. You can't actually make out any specific bump, and you just finish the surgery. Now we have, I think, the largest series of the Impress. We have, I think now it's close to 960 or 980. I don't know, that's what the company people gave the figure, but it's this is the figure of greater than 900 implantations. So 66 for distance 2020 to 2030 at 60 to 70 centimeters, we have gotten greater than 97%, which is a huge plus for a particular patient that is there. And the recommendation to the family would be close to 98% what these people would have. Friends, I would just say that this is a lens which does not cause any specific dysphotopsias. It does not cause any specific knowledge that you need to have for putting it. Furthermore, there are no specific contraindications that I take into account that this is contraindicated for this. Minor decentrations or tilts, etc., it is very forgiving for that particular part. And therefore, as Dr. Ram was saying, that his go-to lens is a multifocal lens, and then he takes out the exclusion. My go-to lens for anybody we are giving as a monofocal is no more a monofocal. I have totally, with the monofocal plus lenses, or whether it's be from this company or any other, that has cannibalized totally my monofocal practice. So I think, again, it's the same thing. Why do companies still make spherical lenses when aspheric lenses are better? So that's a question. They want to sell it cheaper, but I don't know what they get if they can reduce the price of the aspheric lens. The same they can do for a monofocal plus, and that becomes the standard of care then. So in my experience today, or in my practice today, a monofocal plus is the lens that I go for. Monofocals are almost out of the practice until, of course, there is some financial consideration or whatever it is for the patient not to afford. Very low PCO, glistening free, easy to put, etc. Results are outstanding. I don't actually talk to the patient as to what additional I'm going to give him. It's just let it be a wow factor. It's just saying that we are putting it, and there is nothing that I need to discuss with the patient. That's about it. At best, I can say that your plus ad, instead of going from a +3, normally the plus ad that we are getting is about 1.5 to 1.75 in the patients, and obviously everyone has their own. If you do a mini monovision, etc., majority of the time the patient can be spectacle free. So that's all that I wish to say about this particular lens. Thank you very much for your kind attention. Thank you.
Thank you very much, sir. Very nice talk. Indeed, Impress has become a very go-to lens whenever patient is not a suitable candidate for a trifocal. The most important thing is that it does not require additional work of what is traditionally we are doing for a trifocal. And you showed another video, a video in that the injector was brought in, and it is one of the best injectors available in the industry.
We discussed that yesterday. I feel it is really it's really a piece of cake. You can easily push it through. You don't get any tears or lens breakages or the things not coming. So I think from a injector perspective also, they need to be complimented that it's a great injector system that they have developed.
Thank you. So the next talk is by Dr. Anurag Mishra. He's going to talk again on greater degree of spectacle independence for intermediate tasks.
Thank you, sir. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. I'll just expand on what Mahipal sir has already said, and since we discuss a lot and we hear a lot about different IOLs, the design perspectives, the material perspectives, let's put all that debate into place, let's put all that debate into rest and discuss on which IOL would I like to have in my eyes. Should I have a cataract, right? So that should put an end to the discussions that we've been having for such a long time. Here is me. I'm a 50 years old male, or a little more than that. I do have cataract, one or both, doesn't matter. And I have reduced visual acuity for which I need to undergo surgery. That's not all. I have a few requirements. I have a pre-existing compound myopic astigmatism. Compound myopic astigmatism, which is very minimal. I do need to write prescriptions on the screen. I use an EMR to see my patients and write down the findings on the screen. I operate through the microscope light, and every surgical microscope that throws a large amount of coaxial light, some amount of that actually reflects back to the surgeon's eye. So I do not want any glare to happen from the patient's eyes, reflections through the microscope eyepiece again. I am a marathon cyclist. I do bike under the stars. We do take up a lot of cyclothon expeditions under the stars, 200, 250 kilometers running over the night. I love driving. I do love driving my car. I do not even have a driver hired for me, so I always drive myself. And I've subscribed to most of the journals, so I don't have to read a lot of black letter science, so I don't read much of texts. I do read them from the screen. So to compensate all that, my requirements are, I require a crystal clear, undeterred distal visual acuity. I do require lower order aberrations to be neutralized because the quality would then be enhanced. The higher order aberrations to be brought down as minimal as possible. See how the higher order aberrations are doing in my eyes. I need a largely unaided intermediate visual acuity and no glare and distortion. Near comes secondary. These are my requirements. And when it comes to the tris and the EDOFs and we talk about neural adaptation, I'm a busy practitioner, supposed to be. So I cannot afford any time to be given for this so-called neural adaptation to take place. I want my vision bang on the very first post-op day. I can't afford time for that. So let's get on to my measurements. These are my measurements. Nothing much to speak about this, but there's one thing that catches your attention. This is my photopic pupil size, which is 4.2 millimeters. 4.2 millimeters photopic pupil size. Herein, everything's doing fine. The higher order aberrations are onto 0.8. That's okay. The coma and trefoil are fine. They're doing fine. The angle alpha is 0.625. Now, when you choose a particular trifocal and the angle alpha is a particular number, we know that we divide the diameter of that central bullseye, and the angle alpha has to be within that. And I'm a very, very strong believer of the angles playing a role in the adaptability of trifocal IOLs. I do not believe that they don't have a role. They do have a role because I've seen people burning their fingers in that. So with these measurements, the angle alpha being a little on the higher side, and my photopic pupil being at 4.2, what should I choose? I should choose a trifocal. Should I choose a trifocal that has a diffractive zone more than 4 millimeters so that it aids me in reading in photopic conditions? And the central bullseye has to be around 1.2 millimeters because the angle alpha is 0.6. Fine, we do have a product in the market which has both of these. But my measurements are not finished. There's still to come. These are my MTF curves. The cornea is doing fine. The internal MTF is, of course, distorted because I do have a cataract. But what's even more is the higher order aberrations are also doing fine. What's even more is the angle kappa is 0.533. So that makes me essentially unsuitable for any trifocal. Any patient who has an angle kappa of more than 0.3, I declare him unsuitable for trifocal IOLs because my observation has been very contrary to what the industry, what anybody else could believe. So trifocals, as I found out, are a no for me. The next thing that comes in is the EDOF. The EDOF should be the right choice. Again, reminding you that the angle alpha in my case was 0.6, which essentially makes me unsuitable to receive an EDOF, just as this patient. This is a post-operative DLI curve of a patient who had received an EDOF, and look at his angle alpha, it was 0.6 or more than that. Look at the DLI score, 2.05. When this patient came to me extremely dissatisfied with the initial eye surgery, what I did for the other eye was implant another lens with which the patient got bang on DLI of a score of 10 on the internal plane. Which IOL did I put in the other eye? Was the Vivinex Impress. So this is what I take in. Even if this is a solitary anecdotal observation in one patient, I would still stay away from the EDOFs. I do not believe that they are completely angle alpha dependent. So the message I have for myself is, if it's a tri, the kappa is to be looked at. If it's an EDOF, the alpha is something I very strictly look at. This is one patient wherein in the left eye, some other enhanced monofocal was put. And in the other eye, in the right eye, I had put in a Vivinex Impress. This is just one of those patients wherein I have done a match. So the depth of focus, since this is a FS-OTF curve, this takes into account both MTF and point split function, and since they are counter-regulatory to one another. In the right eye, which has the Impress, the depth of focus is slightly less. It's 0.7, as the curve shows. It's slightly more in the other IOL, in the other eye. But if you look at this peak of that graph, it crosses 0.9, the 100% curve. The graph is very steep, so that determines the quality of vision that the patient receives. So what it slightly loses maybe on the count of DOF, it compromises more than compensates for in the terms of quality of vision. So when we subject this patient to this DLI again, this is the right eye, which has the patient's not complaining exactly, but still the DLI score is 9.01. With the Impress eye, it is again stationed at 10. So these are the things that I take into account when I see my patients, with the observations that happen, and the measurements that I have in my eye. I would certainly bang on choose the Vivinex Impress, and I completely agree with my Sir on that. This is actually a universal eye. Don't look at anything. If you're not sure about anything, go ahead and put it in. Now, this was one patient who had come to me demanding for a try. I had selected him for a try too. I'm not saying that I have this sort of a cataract, but this sort of a cataract can also come to you demanding for a spectacle-free vision at all distances. What happened in here is, since the cataract was a lot intermittent and plenty of fluid-filled pockets were there in the mid-periphery, the moment I tried to do a rhexis, it started going out, and the moment I was trying to push in some viscoelastic, it stepped off, and one side of the Argentinian flag happened. As I was trying to retrieve and salvage the capsule, the other side also opened up, making it a complete Argentinian flag. So whatever I had left with me, I tried to manage with that, very minimal rotation, trying to make a rhexis out of it. Following was a slow motion phaco, downing your parameters. Fluidics are always low in my surgeries, whatever. So luckily the cataract was not very hard, all the while looking at the flaps, how they're fluttering, is the flap motility sign positive or negative. Now after I have a bag, I still have enough support for this single piece IOL to go in. So I put in the Vivinex Impress in this case. So what I mean to impress here is, by the Impress is, come whatever the situation may be, whatever compromising situation it might be, and then I just expand the rhexis because I thought the opening was too small under cover of BSS on both sides. So this patient did very well post-operatively. In fact, I couldn't give him a complete spectacle independence as I had promised him initially, but what I gave him was more than he could have wished for. I mean, I could have wished for after landing up in that kind of a compromised situation on the table. So talking about experience, we are not as massive as my Sir is, but still around 90 to 100 implants thus far. And I completely agree with him when he says that we do get a defocus of around 1 to 1.25 at 50. And they all achieve, virtually all of them achieve, barring very few exceptions, an N6 after particularly bilateral implantation. After bilateral implantation with a +1 at 30. So the quality of vision is supreme, and intermediate vision is very good, hardly require any assistance of glasses for intermediate, and for near they need a minimal add of around +1. Max can go up to 1.25. So after bilateral implant, if say the phone is kept on the desk or even on the kitchen platform while the lady is cooking, the call from the number from where the call's coming, the incoming call is coming, is clearly visible on the screen without the assistance of glasses. They can also do their household work, majority of them without the assistance of glasses. For very fine prints, of course, they do need, but it's again around 1 to 1.25, as I mentioned. That's all I had in this edition. Thank you so much for the attention.
Nice presentation, Anurag. Just one quick question. Have you ever had occasion to, or will you ever mix and match, say, an Impress with a Geometric Plus or a Geometric? What situation would you consider that?
Basically, I actually do not mix and match two different concepts. That's not my way of doing things. If I have a situation wherein in one eye it's perfectly suited for a geometric, and in the other eye it is absolutely unsuitable, and the patient does want near vision without glasses, I might just think about, I've never done it, but I might just think about it. But what I've seen in other mix and matches from other manufacturers or other products is that even if it comes with the same material platform, if the concepts are different, the output is a little different on the quality front. So they don't have the same kind of experience with the two eyes. When they compare, they do find differences. So I generally avoid that. But if this is the situation, and after explaining everything to the patient says yes and accepts it, then I might.
Great. Thank you. Next, we have Dr. Sheetal Bra talking to us about Vivinex toric, clinical outcomes and rotation stability.
Thank you, sir. Good afternoon, friends. So it's my pleasure to talk about my experience with the Vivinex toric intraocular lens, and also to share the results of a clinical study that we recently completed and published in Journal of Cataract and Refractive Surgery. The study was done in Netradhama Super Specialty Eye Hospital, and the study looked at the clinical outcomes and rotational stability following the implantation of the Vivinex toric intraocular lens in high myopic eyes versus normal eyes. So as we all know that rotational stability of toric IOLs is a bit questionable in eyes that have preoperative large axial lens. And this is because these eyes have large and loose capsular bags, also weak and relaxed zonules, and the anterior chamber depth is too deep, and the vitreous is also liquefied. And all these factors eventually result in surgical difficulties for the surgeon, as well as increase the likelihood of postoperative rotation if a toric IOL is implanted. So we use this lens, the Vivinex toric multi-cert lens, in the study. The model was XY1ASP, and this model has essentially the optic design, which is biconvex with square, thin, and textured optic edge. The anterior surface has an aspheric design, while the posterior surface has the toric design incorporated. Now the lens can correct cylinder of up to 6 diopters on the IOL plane, and this corresponds to 4.17 diopters at the corneal plane. Now, the most unique feature of this lens is basically its textured haptics, which is nothing but a slight surface modification which is done at the edge of the optic as well as on the surface of the haptics. Now, the haptics have been slightly roughened or frosted with the idea of improving the grip of the optic and the haptics with the capsular bag, thus improving its positional stability. Basically, this is a boon for toric lenses because postoperatively you can expect better stability and least chances of rotation. And this modification, the textured haptics, is available not only on the monofocal platform but also across all the other lenses which are made on the Vivinex platform, such as the Impress enhanced monofocal and the geometric trifocal families. So coming to our study, the purpose was to compare the clinical outcomes and rotational stability following implantation of the Vivinex toric IOL in eyes with normal versus high axial lens. This was a 2-arm retrospective comparative study involving 114 eyes of 114 eligible patients. The procedure performed was flax in all the eyes using the Lens AR femtosecond laser platform with Hoya Vivinex monofocal toric IOL implantation. All the patients were divided into two groups, high axis length and normal axis length. So normal axis length group had 62 eyes, and this group was defined as an axis length less than equal to 23.9 millimeters, and the high axis length group had 52 eyes, which was defined as an axis length equal to or more than 24 millimeters, and the outcomes were evaluated at 1 week and 3 months post-operative. Now, obviously, the groups did significantly differ with respect to the axis length, anterior chamber depth, and white-to-white diameter, and this is what was also expected. However, the corneal astigmatism, if you see, is fairly matched in both the groups. 1.59, which is 1.6 in the normal axial group and 1.7 in the large axial group. So this is the video of the surgery. The operating surgeon was Dr. Sri Ganesh for all the cases. And you can see this is the implantation of the Vivinex toric monofocal IOL. And I hope you can appreciate the textured haptics of the lens, wherein the haptics are a bit roughened. And this is the implantation in the capsular bag based on the IntelliAxis refractive capsulotomy marks, which the LensAR provides on the steep axis of the cornea or on the steep axis or on the axis of the IOL, the toric IOL. So this is the positioning of the lens on the capsulotomy notches provided by the femtolaser. So coming to our results, the number of eyes achieving 20/20 uncorrected vision was 74% in the normal axial group and 73% in the high axial length group, which was almost similar. Eyes achieving post-op SC within plus minus 0.5 was 97% in the normal group and 100% in the high axial group. This was the SE. Coming to refractive cylinder accuracy, the eyes achieving refractive cylinder within plus minus 0.5 was 100% in the normal axial group and 94% in the high axial group. This is how the post-op deviation was evaluated. So the post-op deviation or rotation was derived as the difference of the achieved axis, let's say it was 170, from the intended axis, which was, let's say, 172. So the difference is 2 degrees. And how we did that was basically we took photographs of the eye in dilatation, in retroillumination, and on that, we superimposed an online protractor. You can see this is a protractor, and basically it drew a green line on the axis of wherever the axis of the toric IOL is. So you can see in this particular case, it's somewhere at around 174. So these were the results with regard to the post-op rotation. At 1 week in the normal axial group, the mean rotation was 1.2 degrees versus 1.4 degrees in the high axial group. This difference was not significant. At 3 months, the mean deviation was 1.48 degrees in the normal axial group versus 1.67. And this was also not significant. So you can see even in the large axial group, the mean post-op rotation at 3 months is within 2 degrees. So this is excellent result. And the rotation from 1 week to 3 months on an average in the normal axial group was 0.28 degrees versus 0.3 degrees, which is again similar and not significant. At 3 months, all the eyes in the normal axial group were within 0 to 5 degrees, and 50 eyes in the high axial group were within 0 to 5, and 2 eyes were falling between 6 to 10 degrees. We also did vector analysis and derived correction index, and correction index basically shows how well your cylinder has been corrected. So a correction index of 0 is considered to be normal. Anything more than that shows overcorrection, and anything less than that is undercorrection. So in the normal axial group, the correction index was 1.02, showing just a slight overcorrection of 2%, and in the high axial group, it was 0.99, showing a 1% undercorrection. Again, this was not significant. So you can see that this correction index was close to 0 in both the groups. What we also did was we derived correlations of the post-operative rotation with all the possible preoperative parameters which could affect the postoperative stability of the lens, such as the axial length, Y-to-Y diameter, and the ACD. And we saw that the R values, these are the R values which shows the strength of the correlation of the two variables that you are evaluating. And you can see that the R values are 0, which means that there is, and the P values are not significant, which shows that there was no correlation of any of the postoperative parameters with the postoperative rotation when this lens is used. So normally we say that large axial length and toric lenses can rotate if you have large axial length and large Y-to-Y diameters, but that's with other lenses. When we use this lens, we did not really find any correlation with any of the preoperative factors. And this is another study which is published when they have shown that the mean rotation with the Vivinex platform with the textured haptics was only 1.1 degrees. And we found a similar study that was done using the Acrisof IQ toric IOL in normal versus high axial lengths. And at 3 months in their study, in the normal axial group, their mean rotation was 4.16 degrees versus 4.16. So you can see that with the Acrisof IQ, at 3 months, their average rotation was 4.16 versus 1.48 in our study. And in the large axial length group, their rotation was 4.27 versus only 1.67 in the present study. So you can see that the Acrisof lens, toric lens, rotated by more than double in normal axial lengths as well as large axial lengths. But with the Vivinex toric, this rotation was within 2 degrees for both the groups, which is a very significant result. So to conclude, in the present study, the axial length and Y-to-Y diameter did not significantly correlate with the pre-op toric IOL rotation, and the haptic modification, which is the textured haptics and the surfaces in the Vivinex IOL enhances the contact with the capsular bag, thus resulting in excellent rotational stability in eyes, irrespective of their preoperative parameters. And this is why now I'm not reserved in prescribing this lens and suggesting this lens for patients even with high axial lengths. So the results of the study speak for themselves, and this is the study that has been recently published in the JCRS February issue. So if you're interested, you can go through the details, and if there are any questions, I'll be happy to answer. Thank you so much.
It's a nice study, Sheetal. Corroborates something I find every day.
Yes,
in the
sir.
sense, whenever these haptics are roughened, I think is one of the most important things as far as stability of the
Yes,
lens
sir.
is concerned.
Yeah.
You know, you're always supposed to rotate these lenses in a clockwise direction.
Yes, sir.
The other lenses, I find that if you're slightly off, you can even nudge it a little bit in the anti-clockwise direction. Whereas this lens, I always find it much more difficult. I have to go all the way around and bring it back. It may be a little irritating on the table, but that confirms the fact that the rotational stability of this lens is very good.
Yeah.
And especially considering most of the rotation happens in the first 1 hour, having the lens sitting rock steady within the bag is something which I think your study also proves.
So if you have positioned the lens accurately in its axis at the time of surgery, then the average rotation is very minimum, just about within 2 degrees, and the axial length does not really matter
Thank
when
you.
this lens is used.
Thank you.
Thank
Just a quick question. Has the industry, taken care of vis-a-vis axial length, the size, the overall size with this lens changes? Because in other competition, we have seen that when you are taking very low diopters, it might be the total axial length or the total optic size might be slightly increased to prevent this rotation.
Has anybody
I mean, it's a
I'm
uniform.
not
It's a
aware
uniform.
of
It's a
this,
uniform
No,
size.
I don't know of
I
any
think it's a
company.
uniform
quick,
size across all the axial lengths, and there is no customization of the lens or optic diameter based on the axial length.
I
But
heard one or two Indian companies were trying to address this by increasing the overall size of the lens, the length, overall length,
length of
to fit it into the larger size bag.
that
in
is
myopic
something that would
patients.
be actually ideal. But the texture, the modification also works very well.
So I think that's a very nice study which actually points
No,
down
the
that.
size of the lens bag doesn't always correlate with the axial length or the amount of refractive
But then
error.
the three parameters they've discussed is white to white, overall white to white. So white to white has a role to play when you're talking in terms of the rotation and the ACD.
I think
we'll discuss. Yeah. Thank you.
Thank you.
That's a very nice study and boils down to the rotational stability, and this stands for true for their entire range of products. I mean, be it a geometric toric or a Vivinex toric or the Impress toric. Thank you. So now we have one of the very prolific young dynamic surgeon, Dr. Supriya, who will be presenting on their experience with geometry. All to you, Supriya.
Thank you so much, sir, for the kind introduction. It's a pleasure to be here. Today I'll be bringing us back to the trifocal lenses.
Can we have the slides?
I think it's a different slide.
There's something else.
It's connected to the laptop here.
This one way of telling us our time is over.
Indirectly. So I think for the next session, we'll just take quickly 6 minutes. Sorry for that, running out of time. Okay.
I'll be quick. So I'm just bringing us back. I think everyone's hungry, ready for lunch, so I'll keep it short. Bringing us back to the trifocal lenses and our experience with the combination of geometric in one eye and geometric plus in the other eye. So as we know, the expectations are high these days with trifocal lenses. The other day I was counseling a patient, and like Dr. Anaga initially said, that the first question we generally ask them is, do you do a lot of night driving, a lot of activities at night? And the patient said, no, absolutely no night driving. I've stopped doing the night driving right now. It's done. I only drive during the day. And then I said, okay, if the night driving is, not a major activity in your life, then you can consider trifocals, but you also have these other two options, which are also there. And then they said, anyway, since my near work, my reading is not too much. This was an elderly lady. She was a housewife, not too much night driving. She does drive during the day. And she said, okay, I'll go for a plain monofocal lens. Then I said, okay, can I drive during the day with a plain monofocal lens? I said, yes, absolutely. Your distance vision, quality of vision, clarity, contrast, everything will be really great. For distance vision, you can drive with a monofocal. Then she says, while driving, I can see everything clearly on the road, but I can see my dashboard also very clearly, right, with the monofocal. Then I say, yes. I mean, the intermediate vision would be probably better with an EDOF lens. So you can consider an EDOF lens. And then she says, when I stop in the middle at the signal, sometimes I check my phone and I read my messages. I'll be able to do that, right? And then these are all the activities that I do during driving. I drive during the day, so I'll have all of these activities intact. I don't want to use spectacles in between every time I stop at a signal. So then, these are the expectations of patients from these lenses to correct all of their distance, intermediate, and near vision. So then I counseled her for this lens and said that trifocals are better for her since she doesn't have, night driving or activities at night, and she does actually want a good near vision. So expectations from patients are very high. They want to enjoy life in all dimensions and have an active lifestyle without being troubled by glasses. Now, the trifocal lenses that we use in our practice are the Hoya Geometric Plus lenses, Panoptic lenses. We use Zeiss trifocal lenses, Technis Synergy, and the Rayner trifocal lenses. And the way we counsel lenses and how we actually choose the lenses, again, depends on the activities of the patients and at what level their intermediate work is. So we check the reading distances and check the distances at which they are doing their near and intermediate work. So trifocals were developed to bridge the gap between monofocals and bifocal IOLs in order to provide a significant advantage in terms of postoperative unaided vision and creating a true intermediate focus. It should be noted that an added intermediate focus also causes 2 permanent defocus images instead of 1. So this is a much greater complexity in the manufacturing process, and both of which could degrade the optical quality of the vision, which is why we have patients coming back to us speaking about glare, halos, dysphotopsias, etc. And let's see how these lenses have minimized those effects. So here talking about the Vivinex Geometric and Geometric Plus lenses. Now, there is always a confusion in these lenses, and everyone asks me, is this a mini mono vision? do you have to check dominance? Do you have to do the tolerance test? Do you have to check dominance? And the answer to that is no, this is not a mini monovision. Both the eyes have a near add of 3.5 and an intermediate add of 1.75. And the target refraction for distance for both of these lenses remains 0. So you're not targeting one eye to be slightly myopic. Both eyes are targeted for 0. The difference is that the light, 100% of light entering the eye, is split into 3 different foci. And the amount of light that is split into these 3 different foci is variable. So this is the first company that has actually done this, where they have played around with the distribution of the light rather than having 2 different near adds or having 2 different target refractions for both the eyes. So you're actually fully correcting the vision. There's no refractive error for all distances. You're correcting the distance, intermediate and near refractive error as such. But you're just playing around with the light distribution in both the eyes. So the geometric lens provides excellent distance vision, good intermediate and near vision, while the geometric plus lens provides excellent near vision and good intermediate and distance vision. And toric versions are available from T2 to T6, and it has this preloaded multi-cert injector, which is one of the smoothest injectors that we've ever used. You can use it either as a screw type or a push type injector, and you can actually adjust the nozzle as such, depending on whether you want to do a wound-assisted implantation or inject the nozzle fully into the wound. Now, these are just some of the other details of the lens. It corrects the powers between 10 to 30 diopters, and the recommended incision size, the wound goes, the preloaded injector goes easily in a 2.2 mm incision. So this is the light distribution, like Dr. Anaga has previously attributed to the light distribution in the geometric lens. It splits the light mainly for distance. So 50.8% of the light is distributed for distance, 17.3% for intermediate, and 21.8% for near. Now this is very similar to the other trifocal lenses, where the light distribution for near is somewhere around 20 to 25%. But in the geometric plus, we can note that the light distribution for near is around 32.8%. So much larger light distribution for near, which helps in greater contrast, color vision, and quality of near vision. Okay. So the same add powers are there in both geometric plus is what we've spoken about. But here you can look at the percentage of light loss. So any trifocal lens, yes, there is some amount of light loss. Most trifocal lens, the light losses are around 12 to 14%. But in these particular lenses, it's between 10 to 11% light loss. So light loss is also minimal, but light loss is there since they are diffractive lenses. In our experience, we did a study, 52 eyes of 26 patients with cataract from grade 1 to 4 nuclear sclerosis, and patient had the second eye surgery within 1 week. All patients underwent femtosecond laser-assisted cataract surgery by one single experienced surgeons, and 2-week follow-up were available for all these patients. Now here you can see that 98% of eyes were 6/6 or better at post-op 2 weeks, and all eyes were 6/9 or better. The binocular near visual acuity, you can see that 100% of eyes were N6 and 39% of eyes were even N5. And this is the combination of geometric in one eye and geometric plus in the other eye. The postoperative residual refractive error at 2 weeks, you can see that 94.23% of eyes were within plus or minus 0.5. So this is a great refractive result. We did this test, Salzburg reading test. Is basically a tool for symmetrical evaluation of reading acuity and reading speeds under standardized condition. So this is a patient performing the SRD test. So the reading acuity at different distances, so 40 centimeters, 66 centimeters, and 80 centimeters. So here we found that the visual acuity at 66 centimeters, which is generally the reading distance, was the best. And the reading speeds, that is how fast the patient is reading, number of words per minute. This was also the highest at the 66 centimeter mark. Again, this is the defocus curve. This is something that we've already spoken about. Now, defocus curves are something quite fancy terms that are thrown around, but it's a very, very simple test. What it means that we are inducing a defocus or a spherical power as such. So we make the patient read without glasses, and we make them read the chart, and then we add a defocus, either a plus defocus or a minus defocus, and we make them again read the chart and see the visual acuity with the defocus on. So here you see that without any power at 0, the vision, the logmar is 0.058, somewhere around there. So it's excellent vision. With a minus defocus up till around -2, you see that it maintains. So in the defocus chart, something important to note that anything more than 0.2 logmar is considered functional vision. So you see that you are getting an excellent functional vision up till around -2 to -2.5 defocus. Patient is tolerating that very well, and even a slight plus defocus of 0.5 is well tolerated. This is the contrast sensitivity chart, the FACT chart. So here you see that, any trifocal lenses, yes, they have a subnormal contrast sensitivity, but these lenses, the combination of these lenses are coming almost within the normal range, the lower end of the normal range. So the contrast is also quite good as per the FACT chart. We asked the patient and did a scoring questionnaire where none of these patients actually came back to us complaining about dysphotopsias, but that's generally not how we assess it. We need to ask them positive leading questions about dysphotopsias, and that's what this questionnaire does. And on actually asking the patients if they're seeing glare, seeing halos, seeing dysphotopsias, most of them, some of them, about 9.54 out of 10 of them said that they were not uncomfortable with these dysphotopsias or didn't see them. The rest of them, yes, they did say that they did see some disturbing light phenomenon at night, but they were not, it was not affecting their lifestyle as such, and there were no complaints as such. So trifocals provide improved near, intermediate, and distance vision in presbyopic patients. The use of 3 foci provides significant intermediate visual results without sacrificing near or distance vision. Pairing the geometric and geometric plus, we have found, gives one of the best continuous range of high-quality vision for spectacle independence from distance to intermediate to near. And in our practice, we have used the pair of geometric plus most often for our patients, and we see excellent results with the pairing. Thank you very much for your patient listening.
Very nice presentation, Supriya. I think we have a great family of lenses, excellent material, hydrophobic acrylic, absolutely glistening free, posterior surface modification, which are SPCO, square edge, and then you have the roughening of the haptics so that the rotational stability is there. Then, of course, the trifocal and trifocal plus, which has a unique USP of being the only lens where the light distribution is paired between the two lenses. Overall, and then of course the Impress, which gives you a monofocal plus platform where you want to get some amount of intermediate vision, but where the dysphotopsia is a concern. So truly a great platform, and nice to have multiple choices available to us, and this Hoya group of lenses is something we are all getting accustomed to. And I think the speakers in this session truly did justice to all the different aspects of this wonderful lens. Thank you so much.